Good morning. If you take your seats, we're going to get started. So good to have all of you here today. I want to thank our Sergeant at Arms for being here and helping us so much. They make us feel very safe. Terry McCraw, David Lithicum, Nina Lage, and Bill Riley. Thank you all so much for what you do every day. And we have some wonderful pages with us today, and we appreciate them being here this week. And I understand that they are tired and exhausted, but they are so happy to be here. Is that right? If you all will stand when I call your name. Lucas Keynes, he's representing Representative Dahl. Morgan Davis is representing the Speaker Hall. Manassa Iyer, is that right? Is Speaker Hall. Athara Rathor, Representative Tracy Clark, Jacob Sheff, Representative Todd Carver, and Luella Duncannon, Representative Julie Van Haven. Thank you all so much for being here. Could we just give them a little round of applause? Today we're not voting. Today we have a presentation from the Department of Health and Human Services, behavioral health investment updates, and which one of you are going to start? So Kelly Crosby, Assistant Secretary for Mental Health, Developmental Disabilities, and Substance Abuse Services. Ms. Crosby, it's all yours.
Okay. Oh, how about now? Thank you, Representative White, and thank you to the committee for asking us to be here today. We have some exciting updates to share with you. North Carolina made, and you all made, the largest behavioral health investment in state history. And today we're going to cover the progress and early outcomes. Our focus is on crisis response, justice-involved services, workforce expansion, child welfare, and family well-being, all things that our communities told us were urgently needed. We're going to highlight how these funds are being used, how we're measuring our progress, and what remains ahead. DHHS used a structured, data-driven, publicly facing process to allocate the ARPA funds. And I want to do a quick review of where we've been. In 2024, we released a policy paper to clearly articulate investment priorities and to guide our implementation. After that, we conducted public listening sessions, advisory groups, and monthly updates to ensure transparency. Our decisions were data-driven wherever possible. A particularly good example is for our crisis system, where we used data from our ED boarding dashboard to help locate places in the state where we desperately needed additional crisis services. We used competitive bidding wherever appropriate, and then partnered with counties to accelerate projects that were ready to go. The behavioral health investment framework focuses on four main pillars: mental health, crisis response, the intersection of mental health and the judicial system, our mental health workforce, child welfare, and family well-being. And each pillar targets investments that address both the immediate gaps as well as ensuring that we have long-term system transformation. I'm going to outline and define our funding status criteria because this is particularly important to understand these categories for tracking where the dollars are today and how we've used them throughout our presentation. Obligated means contractually committed, including contracts under development, executed agreements, and signed memorandums of understanding. Expended reflects dollars that are actually drawn down in the NC accounting system. And I want to remind us all that it takes time for obligated dollars to show up as expended, since the state works on a reimbursement basis with the organizations that it funds. Planned represents active projects that are in development. This is our smallest category, and many projects in this grouping will be obligated imminently. I want to start here with an overview of the dollars that were appropriated from ARPA and where we are in terms of obligating those funds and expending those funds. I want to draw your attention to the fact that 96% of the budgeted funds, so $362 million were appropriated from ARPA by the General Assembly, and of those dollars, 348.8 have been obligated. Even more importantly, we have $132.5 million that have already been expended. This shows our strong progress in getting dollars into communities. And of course, we have to balance that with our commitment to responsible planning and spending. Crisis services, justice-involved programs, workforce training, child welfare, and family well-being represent our largest funding allocations. We also made efforts to maximize federal funds as well as leverage private and public partnerships to stretch these dollars further. So for example, we use Medicaid federal match. We use partnerships with private foundations to expand capacity. So for example, our school-based telebehavioral health was also funded by the Duke Endowment. And we used philanthropic investments such as from the Levine Foundation to help support our professional foster parenting. Before I hand this over to Assistant Secretary Kelly Crosby, I want to outline how we will review this investment update in more detail. So we're going to go over each of the major pillars and cover 3 items for each pillar. We're going to overview the core initiatives and funding progress for each pillar. We're going to highlight some key program examples, and then we're going to showcase early and promising outcomes of the work. Assistant Secretary Crosby.
Thank you very much, Dr. Brown. Hello, everyone. It's very good to see you. Thank you, Representative White, Representative Reeder, and members of the committee. As Dr. Brown said, I'm going to go through 3 major areas of investment in our crisis system, our system of mental health and substance use supports for folks in the justice population, and also our workforce dollars. But first, I'm going to start with an overview of our crisis system investments. The crisis system funding is about 99% obligated, and at least 40 million of that obligation is already being drawn down and expended. Investments included standing up new behavioral health urgent care, some of them in your communities, opening new facility-based crisis beds, expanding co-responder teams with law enforcement, deploying additional MORS crisis teams. I believe you heard about MORS last month, and expanding telepsychiatry in rural counties. These investments are building a more modern crisis continuum here in North Carolina. Let me tell you about a few key accomplishments. First, we are trying to make sure that we have an informed public. It's no good having all these crisis services if the public don't actually know they exist. So we had a Crisis to Care campaign, and slowly but surely we are seeing the results of that. More people are recognizing this alternative mental health crisis system. We've launched 9 new MORS teams. That's a crisis response team for children and families. We opened 6 new behavioral health urgent cares in partnership with counties and 1 new facility-based crisis. And all of these structures have been done, as I mentioned, in partnership with counties, communities, LME MCOs. And these investments are about expanding our capacity, but also reducing emergency room dependence. One particular program I want to spotlight, again, you heard about it, one of the teams last month at this meeting. It's our MORS program. So you're going to see all those maroon dots on the map, and that's where we have MORS teams expansions across the state. The MORS programs funded with this investment have kept children in their homes and in their communities. We're preventing institutional placement in EDs, in residential facilities, and also DSS placements across North Carolina with these teams. This is a mobile, family-centered crisis intervention that fills a particular need we have here in North Carolina. So besides just talking about how many of things that we've actually built, let's talk about some of the outcomes that we're seeing. I'm going to give you data from one of our new crisis centers in Alamance. Again, real community effort, and a shout out to the Alamance community for working on this for a very long time. 87% of the people going to the urgent care and 94% of people going to the facility-based crisis were diverted from the emergency department. That's real people. That's lots of people. And 50% of the youth that are being supported by the Morse teams right now are being diverted from out-of-home placement and emergency departments. We also are seeing success from that Crisis to Care campaign. We have seen over 140% increase of people calling 988 if they have a mental health crisis rather than calling 911. And our behavioral health urgent care utilization is up over 360%. So again, people are going to behavioral health urgent cares rather than emergency departments, which is a win. Now I'm going to talk about some additional crisis infrastructure that was funded. Our non-law enforcement transportation is 94% obligated, and the funding for behavioral health technology is almost 100% obligated, and it's showing strong momentum. Our behavioral health technology investments, we call it SCAN. You guys are familiar with that term. SCAN covers a lot of technological infrastructure. It includes school telehealth. It includes behavioral health SCAN, our bed registry that you're familiar with. Our 988, our new mobile crisis dispatch. So mobile crisis can actually be dispatched now from 988, which is very exciting. The NC STEP program that I think many of you are familiar with, which is a telepsychiatry program that supports EDs across the state, and also a new youth virtual mentoring program that is supporting over 9,000 kids right now. So these investments are modernizing our crisis response here in North Carolina, and they're also improving access to crisis mental health services across the state. One program I want to highlight is our non-law enforcement transportation, because we have some exciting program updates since we last gave you an update last fall. As a reminder, non-law enforcement transportation provides crisis transportation for people in mental health crisis without relying on law enforcement transportation. This reduces IVC burden on the system, it reduces burden on magistrates, it reduces strain on law enforcement, it reduces strain on emergency departments. We are planning this pilot launch in October, and it will operate across 7 counties with one regional hub in the east. And the model basically will be a mobile crisis team responding in crisis deployed by 988, and they will be able to transport to the mental health urgent care, the behavioral health urgent care, or a facility-based crisis, depending on the needs of the person. That's exactly what it's supposed to do. So let me tell you about some outcomes. You all know behavioral health SCAN. You know it as our bed registry. It really is our technology backbone for our public crisis system. Since the launch of behavioral health SCAN 2 years ago, we have 13 new types of services in SCAN. So that's our state hospital beds, but it's also all of our community psychiatric beds. Now all of our crisis facility beds are also in there, as well as residential treatment options for kids. So we have 13 new provider types in there. We have launched automated bed tracking, so that's real-time bed availability. That's what we all want. We want to know where the beds are across the state. It's increased by over 1,000%. We have almost 1,000 beds now that are on automated real-time bed availability, and that's growing every day. We are able to see over 3,000 operational beds visible every day in BH Scan. Now I'm going to talk about workforce investments. Workforce investments include our social work leadership program, our direct support professional workforce supports, provider training, and clinician supervision programs. 75% of our funds are obligated, and there's currently additional work underway to address more recruitment and retention challenges that we're seeing across the behavioral health system. Let me talk about some highlights, some key accomplishments. We funded over $3 million for direct support professional recruitment and retention across scores of provider programs here in the state. With the funds, we have expanded a mental health licensed loan forgiveness program up to $20 million. That's very exciting and very new for our field. we launched the Public Leadership Service Program. That is a partnership with 25 schools of social work. And the point of that is to train and recruit social workers that will enter the public system and commit to at least 3 years providing care in the public system. And we've also established a new pathway with the community college system for things we call qualified professionals. That's our entry-level mental health and substance use providers. They're often the backbone. They provide care under licensed professionals, and we need more of them, and we need better pathways. So let me tell you about some of our early outcomes. These are quite exciting. 700, it's actually more than 700 social workers, licensed social workers, have applied for the Public Loan Forgiveness Program, and that includes a 3-year commitment to the public system. With the $20 million, we'll be able to fund about 400 of those. So there's actually a lot of people interested in giving public service. We've already exceeded the funding for the program. We've already seen a 16% growth in the number of entry-level folks who have come through the community college associate degree system. And our new pipeline program with the 25 schools of social work projects 1,500 social workers entering the public system by 2030. So again, we're very excited about these results. Also, as part of Workforce, I'm going to tell you about our collaborative care model. Remember, collaborative care is a model that embeds social workers and psychiatric consultants in primary care because that's where a lot of people actually go for mental health care. 98% of the $5 million allocated, have been obligated. What's more exciting, though, is that collaborative care is delivering strong clinical results across the state already. The funding has supported 61 new primary care practices in providing this service. Over 5,700 people have been served across these 61 programs. That's 5,700 people that got mental health care in primary care, did not have to go to the specialty system. And this is very exciting. 71% of those people receiving care have shown reductions in their symptoms, specifically depression and anxiety, and over 50% have shown full remission in their symptoms. So this program is working. The last thing I'll talk about is our justice system investments. You all invested $99 million to target the intersection of mental health, substance use, and the justice system. 99.5% of that funding has been obligated. The funding happens really in 3 buckets: diversion, treatment, and reentry support. So I have actually a couple of slides to show you. So this slide shows you some of our reentry support programs, like the TASK program. I'll highlight that in a moment. This shows some of our treatment programs like capacity restoration, FACT teams, new units, new justice units at the state psychiatric hospitals. And then lastly, these are our diversion programs, like our law enforcement assisted diversion program. Let me tell you about some key accomplishment. We've launched 7 new law enforcement assisted diversion programs. And this allows law enforcement to redirect people at risk of being arrested to mental health or substance use services. We've expanded in broad reentry support statewide. That includes case management, I'll tell you more about that in a moment, housing and employment supports, and linking people to mental health and substance use treatment. And we also have some new exciting supports for individuals in the juvenile justice system. So we have launched a treatment facility inside of a youth detention center and a new talk-based program for juvenile justice involved youths. And that's all in partnership with Department of Juvenile Justice. One of the programs I want to highlight is the TASK program. As you can see, TASK is a statewide program. That's a win right there. This is something that we have in all 100 counties. TASK is treatment accountability for safer communities. That's what the program is called. It provides assessment, case management, care coordination for individuals leaving carceral settings. It is now scaled, as I mentioned, across 100 counties. The TASK program is going to be incredibly critical in implementing the new assisted outpatient treatment model that's outlined in House Bill 1104. So we really want you to know about TASK and what we're doing to strengthen that program. And finally, I'm going to end on some incredible outcomes. First, we want to talk about our diversion programs. Remember, diverting people instead of being arrested, and this is in partnership with law enforcement, into mental health or substance use treatment. This is North Carolina data also, by the way. This is not national data. Our law enforcement assisted diversion participants, the LEAD program, saw a 50% reduction in arrests in the first 6 months of the program. Recidivism, so rearrests in LEAD participants, dropped 70% compared to the state average. And being in this program produces estimated savings of about $53,000 per person per year compared to the person being incarcerated. Now let's talk about reentry programs. Lots of reentry programs. One of the ones we talk about is our UNC FIT program. So I'm going to talk about some of those outcomes in particular first. UNC FIT, it provides coordinated medical care, behavioral health care, care coordination, housing, employment supports, community health worker supports for individuals. 81% of participants in those programs across multiple counties avoided hospitalization altogether. So hospitalizations, emergency department involvement. This one's critical. 64% engaged in treatment. That's actually double what the typical average is across the state. About 30% of people engaged in treatment. People in this program coming out of carceral settings engaged 64% of the time, which is extraordinary. And mental health symptoms decreased 50% across the people served. So it's helping with their symptoms, it's helping them get connected, and they're not going hospitalized. So they're doing great. We do want to mention some national data just for a second, because our North Carolina data is coming. It's coming, and it's looking really good. But nationally, folks who participate in this program saw a 45% reduction in reincarceration, and they saw far fewer parole and probation violations. So we're hoping to see those same numbers when our North Carolina data comes out. Now I'm going to hand things back over to Dr. Carrie Brown, who is going to talk about our child welfare and family well-being investments.
Great, thank you, Assistant Secretary. We're now on our fourth pillar, child welfare and family well-being. And I want to first, here we go, sorry. I want to start by covering the Division of Mental Health, Developmental Disabilities, and Substance Use Disorders investments. They're focused on quality assurance, physical environment upgrades, crisis intervention training, and launching specialty PRTF units for particularly challenging populations. This work totals $23 million, and 87.5% of those funds have been obligated. I want to share with you some early outcomes of this focus on residential care quality and safety. 100% of our community PRTFs have committed to reducing restrictive interventions, and all of them have been trained in a new model of de-escalation. We have 33 residential treatment centers that have been enhanced to better serve our youth across the state. Combined, this work benefits 255 youth daily via improved environments and improved de-escalation models.
Dr. Brown, do you want to just remind the committee what a PRTF is?
Oh, absolutely. It's a psychiatric residential treatment facility. It is, think of it as a step down from inpatient care designed specifically for youth. So now I'll move on to DCFW's investments in child welfare and family well-being, which focused on improving, DMH was focused on the residential side of the continuum of care, and DCFW focused on improving community level supports for children and families, including behavioral health in schools, respite care, family support, and particularly important are our evidence-based treatments in the community, and therapeutic family placements. This work totals $37.5 million, and 100% of these funds have been obligated. Our early outcomes here show an impact on stability and access. We're strengthening services that help children stay in and return to their homes. Our therapeutic foster care acceptance rates increased to 95%, which is a marked increase from the 65% pre-investment. We have 34 school settings that now have expanded behavioral health access. And really importantly, we have 611 new clinicians that are trained in evidence-based trauma treatment. The Division of Health Service Regulation also focused on child welfare and family well-being, and we really focused on improving time to licensure. So, for example, our timeline to licensure has been markedly decreased. Before the investments, it was taking about 103 days from application to licensing a new youth residential facility, and we've now got that down to 40 days. This has translated into 125 new facilities that youth now have access to, and an additional 503 beds across the state, which are spread across 30 counties. Our DSS investments support placement stability and family reunification. So the DSS portion of Child and Family Wellbeing Pillar totaled $13 million, with 84% of these funds being obligated. And so far, 59 counties have received emergency placement funds to quickly resolve placement challenges for children in DSS custody. We have professional foster care parenting in all 7 DSS regions across the state that has already served 93 children. And really importantly, of those 93 children, those that have been discharged from professional foster parenting, 74% were discharged home. So they were reunited with their birth families. Chair and members of the committee, I want to thank you for your time today. The North Carolina General Assembly's historic investment in behavioral health, is now translating to real impact for North Carolinians. We've seen expanded crisis response, stronger supports for justice-involved individuals, and safer, more stable options for children and families. We've obligated nearly all the funds. We have projects underway in every region, and the early outcomes are showing improved access to care, fewer arrests, better treatment engagement, and better supported children and families. We appreciate your partnership in working with DHHS and the local communities to build a stronger and more responsive system. And we're looking forward to continue on this work. And we'd be happy to take any questions.
Thank you all both so very much. This has been very informational. We really appreciate it. Thank you. Are there any questions? Representative Blackwell.
A couple of questions, if I may.
Yes, sir.
Regarding BH Scan, is that fully operational now?
It is fully operational, yes.
And does it allow a sheriff, for example, to reserve a bed, or does it just tell them it's there now, but it may not be after you drive 3 hours?
So the challenge with what it does allow you to do is to refer a patient to an open bed. I think that the challenge is that you can't really reserve a bed until you know that someone meets medical necessity for that particular level of care. So it is true that a sheriff could look in the system and see that a particular facility has open beds, and perhaps even initiate the referral. But until that individual is evaluated by the accepting facility, determined to meet medical necessity and actually admitted, that's the challenge with the way our system is organized. Is it's hard to make it happen that way.
Are you planning to reorganize it so it doesn't work that way?
I think what we can do is, I'm not sure that we can change the structure of our healthcare reimbursement system that exists here in North Carolina, which is the whole medical necessity piece that's beyond our authority or scope. But as we improve the referral capabilities within BH Scan, and as we build the system so that there's more overall availability, that I think it'll work more smoothly and actually help people identify where there are open beds, so that we don't want to waste people's time driving across the state. That's not a good use of anybody's time.
Well, if I may, Madam Chair.
Yes, please.
It seems to me that the department should focus in this particular on getting the evaluation that's needed done before they do a reservation. But having to drive 3 hours, it's sort of like, can we not do telehealth or something to do the evaluation and then do the reservation? Just to say system won't let us do stuff, I find disconcerting.
Oh, now I understand where you're going, Representative Blackwell. So actually that functionality I think that you're talking about would exist now. So what a sheriff would need to do is to bring an individual to the closest emergency department. Then they could be evaluated at that emergency department, and we know that our emergency departments across the state, once they've determined what level of care that individual needs, then they can use BH scan to figure out where there's an open bed and have the individual transported there. And at that point, the patient is already accepted, and so the bed is reserved. So the way it would work is rather than the sheriff just looking in the system to find an available bed, the sheriff goes to the emergency department or behavioral health, urgent care, whatever facility is closest and most convenient for them. They get evaluated there, determine the level of care that's appropriate, and if they need, for example, an inpatient bed, then we use the BH scan to identify that bed. The bed is now reserved, and then if the sheriff is the one that's doing the transporting, they know that they're just they know that they can just drop that individual off and without a problem, and then return. So I think that's the way it could work to meet those needs.
I look forward to hearing more about that. Yeah, ask one more question on this topic and then yield to anybody else.
You may.
With reference to BH scan, does that also tell, and I'm using sheriff as an example, does that also tell the sheriff about the availability of third-party beds or private beds that may be available? Are they incorporated into the system?
Yes, we have almost all of the inpatient psychiatric beds are in the system. We are missing a few freestanding psychiatric facilities, although one of them, for example, I believe it's Bryn Mawr, has just agreed to get onboarded onto BH scan. Many of the remaining facilities don't have electronic medical records themselves yet, and so that has delayed their ability to and willingness to join BH scan. But our plan is to get every single bed in the entire state on the system.
Madam Chair, I've got one other, but I'll let you go to somebody else, and if there's time, come back to me if you would.
If you would like to finish your question, then we'll go to somebody else.
Oh, aren't you nice?
I am.
So glad Representative Potts, he's over there. Which?
I believe your time's up.
You're not.
I knew you would think that. On page 12, you say that the non-law enforcement transportation pilot aims to reduce unnecessary and voluntary commitments. I'm a little bit unclear on reducing unnecessary commitments through a transportation pilot. Are you simply saying getting them to somewhere that somebody can look and say, hey, you don't really need to be committed?
This is a superb question, Representative Blackwell. I could have planted your question actually, because this is one of the biggest challenges in our system right now. So what's happening in present state is that we have patients that are being involuntarily committed simply to transport them, to obligate a sheriff so that the sheriff will come pick them up and move them to the next facility, where they don't actually need to be involuntarily committed. So the idea is that if we have transportation, then individuals that can voluntarily sign themselves into treatment can voluntarily sign themselves into treatment, and we won't misuse the involuntary commitment process just for transportation. And that's unfortunately happening in our system today.
Well, I guess my concern is that in the desire to avoid unnecessary, that the cost of providing and the problems of providing needed services don't end up causing us to try to not commit people who really need to be there because we just like to have fewer people there.
Absolutely.
Thanks for an excellent presentation and using the investment that we made. One of the questions in a number of these new programs, new facilities and things like that, I come back to our sustainability of this and the need for ongoing funding. As we all know that this was one-time money that set up a lot of services. And is that for the future to know what are these sustainability for these different programs and what and I guess the worry is that next year we're going to come back in the budget and say, hey, these are all great programs with that great outcomes, but we need some numbers of hundreds of millions of dollars.
That's a very fair question. And when we chose how we would invest these dollars, we did it with an eye towards sustainability. So, for example, the 80 million that was allocated to our crisis system, much of that actually went to brick and mortar because that's a good use of one-time dollars. So there won't be a repeated request, for example, for the majority of those dollars. We did the same in every area where we could figure out ways to make it sustainable. We did. So our goal is to make as many of these projects self-sustaining so that we won't have to come back and ask for any additional funding.
Do you have yet a sense of how many of them are going to be sustaining and what you're thinking about for next year? And I'm not going to hold you to the number. I'm just trying to get a sense.
I don't feel like I don't have a great, I'll give you an example. Here's what I can do. I can give you an example of something that I know we will need additional funding, and that is in our detention and community-based capacity restoration. So that's something that we use with our justice dollars. And that allows us to maximize the use of our state psychiatric beds by taking individuals that are incapable to proceed and letting them be treated in the jails and in the community rather than taking up a state psychiatric bed if they don't need one. So that's an example of a program that's got pretty remarkable outcomes. They've been restoring individuals 3 times faster, and it's about a third the cost of a state psychiatric hospital bed, but that would require longer term investment. And I can tell you that that's something that we've been collecting our outcome data with the intention that we would want to consider coming back to you all with that data to see if it's a program that could continue. I'll give another example of funding. For example, all the workforce stuff, we're not going to need additional funding in the sense that we've already got the clinicians out there. So for the 611 clinicians that are trained in evidence-based trauma treatment for children, they're there. Of course, you could do further investments, but there's no need to, it'll be self-sustaining in terms of as long as those individuals stay in practice. And so particularly with a workforce, it was designed to be a one-time influx of support for a behavioral health workforce. And again, not need recurring dollars. So I would say, this is off the top of my head, that the majority, majority will not require, but there will be a small minority that will require potentially some increased investment. But I can get you a much better number with a little bit of backroom homework.
Thanks very much.
Representative Miller.
Thank you, Madam Chair, and thank you for the presentation. I'm going to expand a little bit on what Representative Blackwell was talking about as far as sheriffs and transportation. So if I heard you correctly, and I think we've had this conversation when you presented before the IVC committee, talking about marrying you and the Sheriff's Association. Are y'all working together on this?
Yes, sir.
And are we making progress?
Yeah, I will. If you want to have additional details, I'd be happy to have Assistant Secretary Crosby, because she's been working directly with the Sheriff's Association, and she can give you a quick update if that would be possible.
I would like to actually meet offline, in my office or something, and I can get Jansen to set that up. But what concerns me is I think I heard you say that I go to Dr. Reeder's ER in Greenville. I guess that's where you're at, isn't it? In Greenville. And I have a patient, and we look for a bed, and say the closest bed is, I'm just going to use this as an example, Asheville. And you're telling me that when we get to Asheville, we have to be evaluated again in Asheville?
No, sir. What I was talking about was if the sheriff themselves were just to look in BH scan to where there's an open bed and drive to that open bed, then the individual would have to be evaluated when they arrived. If they go to the local ED, the evaluation's already done.
Yeah, well, you have to do that anyhow. We've always done it that way.
Yeah, so then that should...
Okay, but we can lock that bed in at our ED.
Correct.
On the initial evaluation.
Yes, that's the idea. You make the referral in the system. Once the accepting facility has accepted that bed is held until that individual arrives.
Okay, follow up.
Follow up.
And I heard real quickly, I heard you talking about incapable to proceed.
Oh, yes, sir.
Are you talking about putting those folks back into county jails to?
Yeah, so what I'm talking about there are that we have individuals that have been charged with a crime. The judge has adjudicated them incapable to proceed due to their mental illness, so they can't participate in their own defense. The majority of those individuals go to the state psychiatric hospital to have that capacity restored so that they can proceed with their charges, because they're sort of in the no man's land in the middle, where all the charges, all the proceedings are on hold until capacity is restored. What we have done is we've set up an entire system of capacity restoration. So it used to be that the only option were our 3 state psychiatric hospitals. We've now built 3 regional detention-based facilities that have capacity restoration programming within the detention center. And we also have, within 3 different areas of the state, we have community-based capacity restoration. So for the individuals where a judge is willing to allow them to be released on bond, then the individual could go get their capacity restored in the community. Otherwise, the options are the detention center, or if they really need an inpatient psychiatric level of care, the state psychiatric hospital. But that way we make sure that the individuals that are going to the state psychiatric hospital are those that actually need an inpatient level of care. And it's much more efficient for individuals that don't need a state hospital bed. Rather than waiting for one, they can go into a detention-based program. They could do that today and get restored faster and move on with their charges. And these are, in Pitt County and Mecklenburg County, they are dedicated units that are just for this capacity restoration program. And in both Mecklenburg and Pitt County, any sheriff could participate. So you don't have to be, it's not just like Pitt County and Meck County those programs serve individuals that come from all over the state. As long as the sheriff of the sending county has agreed, entered into an agreement with the Mecklenburg sheriff or the Pitt County sheriff, they can serve those individuals. So we're trying to make it so that it's a whole statewide system using those sort of 3 anchors, if that makes sense.
It does for right now. Thank you.
Representative Purtle.
Thank you. And thank you for the presentation. A couple of questions. On page 10, with the CIS or CSI investments, rather, the crisis system investments, that data did all that come from Alamance County?
Yes, it did.
So hopefully we will get data more statewide to see.
Correct.
But just that snapshot in that particular time period, that's where that data comes from. Okay, my second is more of a comment, if I may, Mr. Is very disturbing when my colleagues spoke about the transportation component, that somebody would manipulate the legal structure of commitment just for transportation purposes, and I hope there's some way we can remedy that in the future. That is that's a dangerous path to even know. I wished I hadn't heard it, to be honest with you. It's very alarming. And then the third thing about the behavioral health scan, I'm 100% behind this program. However, I guess in all my time in the behavioral health system under the law enforcement purpose or law enforcement side, I was always under the understanding there's the initial exam done if the respondent's found to meet the criteria for inpatient treatment. The sheriff's department did the transport to a facility. But once arriving upon a facility, it wasn't a drop-off situation. I was always under the understanding was that respondent was evaluated again by a psychologist to ensure that they met the criteria for the inpatient. So there was a receiving process, not just the sheriff's department dropped them off, that the respondent was evaluated again and accepted. And that's the way that I always understood that it occurred, because you may have and no offense, Dr. Reeder, but you may have an ER doc finding the initial criteria was met, but then you get to the facility and it would actually be a psychologist or a psychiatrist that would do the evaluation, a much more thorough evaluation. And then that responded, and that's the way I felt like it should be, because we're taking somebody and we're taking all their rights. We are against their will, and they're being committed to the facility. So are you telling me that doesn't exist anymore? Do I understand that? Because I don't think it's simply just a drop off. It's a handoff, and that handoff there's a receiving process and a delivery process. Thank you, Ms. Joe.
So you raised some important points. It gets complicated quickly because there's two very closely related concepts. So one is, do they meet medical necessity for an admission, which is essentially related to, I'll be frank, whether the hospital is going to get reimbursed for the stay from the insurance company. That's an entirely separate but related but separate process than involuntary commitment. So theoretically, if you've reserved a bed through BH Scan, you've reserved an inpatient bed, they've already gotten all the records, they've already decided that this individual meets medical necessity criteria, and they're reserving that bed for that individual. When that individual arrives, they will, you're right, within 24 hours, but it's within 24 hours of arriving at the psychiatric facility, a second evaluator needs to make the determination as to whether they meet involuntary commitment criteria, not whether they meet medical necessity to be admitted, just whether they meet involuntary commitment. Because that second evaluator could switch them over to voluntary. And that's that's the ideal situation, right? Is that maybe somebody wasn't ready for treatment at the time that they presented to the emergency department. They got a little bit of treatment in the emergency department. They identified a bed, they arrive, but then they're willing to stay once they arrive at the inpatient psych facility. And that's where you do the second. So the two evals still exist, but that's purely related to the civil involuntary commitment process, and the timing of the two evaluations and the 10 days till you go before a judge, et cetera, et cetera. The other process is just whether you meet insurance criteria for admission.
Thank you. Representative Wheatley.
Thank you, Madam Chairman. Just wanting to know how difficult it would be to get information just on the county that I'm serving, and to where I understand exactly what's transpiring as far as the Sheriff's Department, who's being transported, who's still in the, being held in the hospital area, in the emergency rooms. Is that possible? Just to get the information on my county?
Yeah, we would be happy to share whatever information we do have. I think what would be challenging, like if you're talking about behavioral health holds, that data is owned by the hospital, so we could give you summary data for that county to say we have, on average, you have X number of individuals that are waiting are on a behavioral health hold. We could do that. We couldn't give you down to the hospital level because that's not permitted by our agreement with NCHA for the NC Detect system that we use. But yes, we could give you summary data for your county. If you're talking about, we have summary data on how many individuals are in emergency departments in every county in the state awaiting behavioral health treatment.
If that would be helpful, thank you.
Thank you. Representative Shepherd.
Thank you, Madam Chair. Yes, ma'am, thank you for your presentation. I want to go back a few years. When I first came to Raleigh, we
We
consolidated.
don't have that much time.
Ma'am?
I said we don't have that much time for you to go back a few years. I'm just
Now, wait a minute. If you
I'm
got time
just
for
kidding
if
you.
you got time for here, you got time for me. But when I first came here, we consolidated a lot. We were in a crisis as far as spending and money in the state in 2011. But with that, I think we took a hit on mental health. At that time in Onslow County, Onslow and Carteret had a mental health facility that worked together. And when there were emergencies, there was somebody within 30 minutes there usually. If they had an emergency and the sheriff department could call, they were there. Since then, they consolidated, and we're with, I think, Brunswick, New Hanover, Onslow, Carteret. All of us are together. And sometimes when we have an emergency in Onslow County, they have to get somebody from Wilmington to come, and by the time they get there, the sheriff department's already taken care of the situation or whatever. My point is, are we still in that position, or are we ever going to get to the point where we consolidate, where we've got more people that are there sooner and faster than having to come from an hour and a half away? Do you understand what I'm saying?
So are you basically saying, are we going to get to a position where we have enough beds in every county so that individuals that need treatment have access to treatment in their home county? Is that, or did I apologize if I misunderstood?
Yes, ma'am. Follow up. To that point, but also some of them need to go to more specialized places. I understand that. And at one time, and you guys correct me if I'm wrong, I've been here for so long I forgot some things, but at one time it's either go to Cherry Hospital or go to Broughton in the western part of the state, or come to Raleigh to Dorothea Dix if it was more specialized treatment. But sometimes these situations are just drug abuse, alcohol, and they would come to, we had a local place where they'd go and they'd sleep it off, they'd get care, they would be fed, and all these things. And then when they were over that little episode where they had the withdrawals and so forth, they would probably be allowed to go back home. But in this situation now, sometimes they stay at the hospital, or we're staying at the emergency rooms for 2 or 3 days or a week or more before they could get them transferred. And I want to know where we are with all that, because I think we took a hit when we decided to consolidate, and we had something good going, and now it's not quite like that. Thank you.
Deputy Secretary, I'm going to ask you if you would meet with Representative Shepherd offline.
I'd be happy to.
We do have one more question for you, and we are running out of time. So, Representative Crawford.
Thank you, Madam Chair. First, thank you for the presentation. I have hopefully 2 quick questions. The work that you all have done to do trainings, for example, in the PRTFs, I think all of that's great. When will we have some outcome data and evaluation on how that training is working?
So all of the community PRTFs have now been trained. So I would say, in order to have sufficient data to make it meaningful, would probably be about a year from, a little less than a year from now. We'll be able to see, because we did collect baseline data, so we know how many restrictive interventions take place in each PRTF or in community PRTFs in general. Before we trained everybody in UCARU, which is the de-escalation model that we chose. So then now we can look at the same numbers, but we want to give it at least 6 to 12 months, and the training is just recently completed. So, but soon-ish.
Thank you. And then one additional quick question, and this is a little bit broader than just the crisis system that we have. Have we done any work on some detailed workforce mapping to see really where we have our mental health professionals across the state? Are they actually doing services, or are they just on the rolls as doing services? Have we done any of that work? And this is coming out of some recent information that I've gotten from some other states. And if we need to do a follow-up, we can do that.
Yeah, so I think what you're asking is, are you looking at particularly how many providers are billing Medicaid?
I think how many providers are actually providing services. They're not just licensed on the rolls. How many are providing services? How many of those providers are full-time or full-time equivalents, so that we really have an understanding of where and what the potential gaps are.
So we can do that with Medicaid data. We obviously don't have other payer data to be able to tell whether individuals are. Oh, we have an answer.
Excellent.
It's got to be quick because we've got one more question.
Hey, Representative Crawford. Yeah, it's very new. So, sorry, Dr. Brent. Yeah, we actually have done that with Wednesday. So, part of the funding for the workforce study. So, the number of mental health and substance use professionals by profession who are not only enrolled but actually billing and providing services in the public system. So, we have that. We need that baseline data, right? So we see the many counties, quite frankly, it's the majority of the counties do not have enough practicing clinicians. Kind of coupling that with this program pipeline that we're creating. So now we know where we're missing. Those are the counties we're going to target with our pipeline system.
Thank you.
We can share all of that with you. It's pretty cool data.
Representative Cotham.
Thank you, Madam Chair. For the sake of time, I'll try to go quietly. Thank you so much for this very thorough and impressive presentation. On page 26, you talked about re-entry, and that is a very, very important topic and the work that you're doing. A quick question that you can follow up with an email. I didn't see anything mentioned specifically really about families, but then children in general, of how you're helping to assist families and children with their parent who may be coming home from treatment or from being incarcerated.
Sure, we're happy to follow up. Yeah, that's through our juvenile justice work, so we'd be happy to follow up with that.
Thank you all so much for being with us today. You've given us lots of great information, and I know that we can contact you individually if we need to follow up from questions that we've had. So thank you so much for being here today.
Absolutely, thank you.
It's not 1 o'clock yet.